Assalamu alaikum everyone.
Walaikum assalam, ma'am.
Is the voice clear?
Yes, ma'am.
आवाज आ रही है सबको?
Yes, ma'am.
Okay. Today's topic is Leishmania, and this is going to be the last topic which we are going to discuss in the protozoology. This is with the completion of this topic, we are going to finish with the organisms or with the parasites, which we are going to study in protozoology. So Leishmania is basically a disease which has been named after the discoverer. He was Sir William Leishman, and he discovered that this was caused by a flagellate, which is and it causes a disease which is known as Leishmaniasis or Kala-Azar. Flagellate means that it's a morphological form which has a flagella and which is able to move about. It has a variety of manifestations. It has a worldwide distribution throughout the tropics and the subtropics, and its vector is the sandfly. It is transmitted by the genus Phlebotomus, and the sandfly is one of the species of that genus. A large number of people are at risk, they become infected, and we can see a large number of clinical cases every year. It's divided basically into three species: Leishmania donovani, tropica, and Resiliences. They have a different geographical distribution and a different presentation. Donovani produces a disease which is more involving the organs of the body, and it is known as visceral leishmaniasis or Kala-Azar very commonly. And this was supposed to be this was rather a very common disease in the past, especially in the subcontinent. In India, you would see a lot of people, a lot of patients with leishmaniasis. Leishmania tropica, mostly in the tropical areas, and it produces a localized cutaneous leishmaniasis. When the Braziliensis species, it is going to cause a mucocutaneous, that it is going to involve the skin as well as the layers, mucosal layers underneath it as well. So three species. The most important one is donovani, and this is the most important one on which you will get an SCQ or MCQ. Parasitology is basically a topic which is very commonly asked in your viva, because these are small things which most of the people know, most of the examiners know, even if their specialty is not microbiology. And they tend to start the viva with a few questions from parasitology. Visceral leishmaniasis, that is Leishmania donovani, it is found in most parts of the world, and the most important area where you can see it is prevalent, and that is the Indo-Pak region. Then this is cutaneous leishmaniasis. Again, there's a focal distribution throughout the world. Habitat, it's a strict intracellular parasite. It is going to be found within the macrophages or other reticular endothelial cells. Various animals as well as humans can become infected with the Leishmania organism. Amongst the animals, it could be the domestic dogs, it could be the wild dogs, it could be the fox, wolves. These types of animals, they can become a site for the invasion by the Leishmania and production of the disease. There are two forms. Number one is the Can you hear me?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
Okay. So the transmission is through an insect vector, and that is the sandfly. Vertical transmission sometimes occurs from the mother to the fetus in utero, and they could also be transmitted through the blood, because these are the blood flagellates and the tissue flagellates. The sandfly, which is the vector, it is the only female of this species is going to be the vector for the transmission of the disease, because the female sucks the blood typically at night, and during its own entire life, it is going to take 2 to 3 blood meals, and its lifespan is about 2 weeks. Once it has taken up the blood, it is going to transmit the promastigotes. Sorry, it is going to take up the amastigotes from blood meal of an individual who has been infected with Leishmania. And once amastigotes, they go into the system, then they are going to be converted into the promastigotes, and these promastigotes are during the bite of the insect when it feeds on the blood, they are going to be transmitted into the saliva, and from the saliva they can go into the skin of that individual. Morphologically, there are 2 forms, amastigotes and promastigotes, as you were talking about. And amastigote is a rounded structure. It has a nucleus, it has a basal body, it has a kinetoplast, and it is always going to be found within the cells. You just need to remember that it's an intracellular structure. It is rounded in shape, having a nucleus, a kinetoplast, as well as a basal body. And this is going to be found in the vertebrate host. That is, it is going to be found in humans. It is going to be found in the animals which are infected with this organism or with this disease. So this is what you will see. This is a macrophage, and this is the stained slide, which is showing you the amastigote forms. And this is the diagrammatic representation. Promastigote, on the other hand, is an elongated structure. Again, it has a nucleus, it has a kinetoplast, and then there is a flagellum, which helps in the motility of the top. Amastigote is non-motile. The promastigote is motile, and it is motile by means of this free flagellum, which originates from one end of the parasite. And here is a stained picture of the tissues in which you can see these promastigote forms. Basic life cycle of the Leishmania circulates between the vertebrate host and the invertebrate vector. That is the host and the sandfly. So the host is fed, the sandfly feeds on the blood of the host, takes up the forms, and then the promastigote forms are going to be injected during feeding into the host. So it's a very simple life cycle alternating between the vertebrate host and the invertebrate vector. To show you the details of the life cycle, over here you have let's start from here. The sandfly is going to sit on the human skin, and it is going to take up a blood. Over here, it is going to inject these promastigote forms which develop in the body of the sandfly. These promastigote forms would be taken up by the macrophages, and within the macrophages, they are going to be transforming into the amastigote or the rounded structures. And once this they start multiplying by binary fission. When a large number have been produced, this macrophage is going to burst open, and with the bursting open, these amastigote forms are going to go into the tissues. They are also going to be present in the blood, and so when the sandfly is going to take up the blood meal, it ingests the macrophages, which are infected with the amastigote forms, or they can ingest the amastigotes as well. Then the other part of the life cycle of the Leishmania that occurs within the body of the sandfly. Over here, they are going to be ingested, then they are going to be transformed into the promastigotes, into gut of the sandfly, and then they will undergo binary division, increasing their number, and finally they will go and settle down in the mouth, and from there, with the saliva, they will be injected into the human. So infective stage is from here. This is the infective stage, and diagnosis is when they are within the macrophages, and we are going to look for the amastigote forms. Another simplified version, you can use that slide, or you can use this slide, in which the sandfly, these are the mammals which become infected by the sandfly, and these are taken up by the macrophages, amastigotes. They are going to be transformed in the promastigotes are going to be transformed into amastigotes, and they are taken up by the sandfly. That changes into the promastigotes, and the cycle is completed. Coming to the pathogenesis. Amastigote forms, they are going to proliferate within the tissues. They will be taken up by the macrophagic cells, by the endothelial cells, and once the macrophages, they are filled with the amastigote forms, the macrophage is going to be lysed. And once it lyses, it is going to release the amastigote forms. This is going to initiate an immune response by the host, and this will result in the formation of a granuloma. If this granuloma ulcerates, it can become pyogenic, and these lesions can be seen on the surface of an individual. Clinically, we see three types of symptoms associated with Leishmania. Number one is the visceral leishmaniasis. Number two is cutaneous. And number three is mucocutaneous, as we discussed. The factors which determine the disease presentation would depend upon the leishmanial species, the area where the sandfly is going to be predominant, and the immune response of the host. We are first going to talk about Leishmania donovani, which is the causative agent of visceral leishmaniasis, or Kala-Azar. Why it was called Kala-Azar? This term was introduced in probably the subcontinent, because the individuals who were suffering from this disease, they would have certain changes in their skin, and the skin would become dark colored. So Kala means black, and that was the presentation of the individual, and so that name came to exist in such patients. Visceral leishmaniasis further has different species depending upon the area in which that parasite is found, but basically we are concentrating on Leishmania donovani because this is the species which is most commonly seen in Pakistan, in India. And in Pakistan, it is the Dera Ghazi Khan area, that side, that belt, which is most common because the sandfly is prevalent in that area. The vector is present over there. So we will see cases of visceral leishmaniasis in that area, and sometimes those patients, if they are not diagnosed properly, they will come to the bigger hospitals in Punjab, and we will see these cases in Lahore, Multan, etc. Reticuloendothelial system is affected, liver, spleen, bone marrow, lymph node, and depending upon the involvement of the tissues, they will be an increase in the size of these, and if the disease is long-standing. Onset is generally very gradual. The disease progresses gradually, and it is associated with death in 2-3 years if the patient remains untreated. Initially, in the olden days, there was the diagnostic problems were there, and the treatment facilities were not available. But nowadays, I think we have got lots of drugs which can cure this condition. Incubation period is 2 to 6 months, but it can be as less as 10 days, and it can be extended up to years. Fever, malaise, weakness, wasting, although there is no loss of appetite. On examination, spleen can be enlarged, there can be hepatomegaly, there can be enlargement of the lymph nodes. And I said it all depends upon the response of the individual and the number of organisms which are present. Laboratory studies would indicate that there is a depression in the bone marrow and their functions are going to be decreased. Patient will have anemia, leukopenia, and thrombocytopenia. That is, the hemoglobin would be low, the WBC count would be low, the platelets would be low, and because of the lower platelets, there will be petechial hemorrhages or spin point hemorrhages, not in the mucosa as well as on the skin surfaces. So this is a clinical picture of a person with the visceral leishmaniasis, and as you can see, the darkness of these hands which are going onto the palm as well. And because of this reason, it was coined as Kalazar. This child is showing both hepato and splenomegaly. The second species is that of Leishmania tropica, and it is a causative agent of cutaneous leishmaniasis, and this is the lesion which is visible, and most of the time it's a solitary lesion, and it is also known as the oriental sore. Incubation period is weeks to several months. It produces a chronic granulomatous response, which is localized to the skin. This can become ulcerated, it can produce a nodular lesion, and it can at times resemble leprosy as well. And it's most commonly again in those parts of the tropics and the subtropics where the sandfly is very common. Lesion is painless, it is tender, it is itchy, and you will see the lymph nodes draining that area. They may become enlarged and palpable. Although it can persist for months to years, it's a self-healing lesion even if it is not treated. The third species is the Leishmania brasiliensis, and the condition which it causes is known as mucocutaneous leishmaniasis, which is also known as spondia. Most commonly seen in the American South, Central and South America, the chronic skin lesions invade the mucous membrane. Starts with a simple lesion, and then it progresses, it goes deeper into the tissues, involving the mucosa and presenting a more severe form of the disease. From the mucosa, it can metastasize to the other systems in the body via the blood or the lymphatics. Most commonly involved areas are the oropharynx and the nasal mucosa, which is responsible for the disfiguring of the face, as you can see in this individual. So this area is most commonly involved in mucocutaneous leishmaniasis. Primary lesion may be present and then a small lesion, and it can persist for a very long time, and the complications can occur a long time after the primary lesion. And there is a persistent presence of a hypersensitivity reaction to the presence of these organisms in the body, which also is contributing to the damage produced by the tissues. Clear up to this point? Any questions?
No, ma'am.
There are two components of the diagnosis. Number one is the clinical diagnosis, and number two is the laboratory diagnosis. The clinical diagnosis depends upon two types of tests: non-specific tests, which will give you the indication of the disease, and the specific test, which will point out the presence of leishmania. Non-specific include, number one is the blood examination, which would show you that there is a leukopenia, and this leukopenia or a decrease in the WBC count is progressing with the passage of time. That is, the WBC count is gradually falling as the time goes on. And most of the monocytes and lymphocytes are the cells which are going to be most commonly reduced. WBC RBC ratio normally is when for each WBC there are 750 RBC. Over here, for each WBC, the count goes up to 1,000. Then the complement fixation test, Wassermann reaction, that is also going to be positive and indicative of leishmania, but it's a non-specific test which is going to be positive in other conditions as well. We've discussed, then just forget about the description over here. Just remember that another non-specific test is that the albumin globulin ratio is reversed. Then we have the electrophoresis, which may show an increase in the globulins. Normally the albumins are high, the globulins are low, but in this case the globulin increase in quantity and the albumin, they are low in level. So the electrophoresis will show up the hyperglobulinemia. specific test which indicate the presence of the organism in the body is targeting the demonstration of the amastigote forms and the isolation of the parasite as well as the serology. Demonstration of the amastigote forms, they are also known as the LD bodies or the LD forms, and LD stands for Leishmania jonovani. So these forms, when in case of Kala-Azar, they are also called by the name of LD, and you can get a short essay question or you can get an MCQ on what are LD bodies. So we will make a slide from the splenic aspirate or the bone marrow or a thick blood film. We will stain them and we will then scan the slide for the presence of these amastigote forms within the macrophage. Here you can see them, and over here also you can appreciate the presence within. This is one macrophage and this is the nucleus, and all of these are the amastigote forms or the LD form, LD bodies. Isolation of the parasite is through culture, and as we culture the bacteria, we can also culture the parasites, but the media is different. And on the culture, you will see the promastigote forms. You need to remember that in the tissues, it is the amastigote form, and on the artificial culture, yeah, outside the body, it is going to be the promastigote forms. Then third is the animal inoculation test, and the animals which we use for this purpose are the hamsters or the mice. Intraperitoneally, the specimen is injected, then the animal is killed, and 2 to 3 months later, the animal is killed, and then the liver and the spleen are removed and examined for the presence of the amastigote forms. Because in the tissues, it is the amastigote, not the promastigote form, which is going to be seen. Serology depends upon number one is a skin test, which is known as the Leishmania or the Montenegro test, and this is based upon the delayed hypersensitivity reaction. And this is similar to which test which we've already done? Which was the other skin test we studied a few days back?
Tuberculin test.
Tuberculin test.
Tuberculin test. So again, this it's the same intradermal injection of the Leishmanian antigen is given, and then we leave it for 48 to 72 hours, and after that we look for the induration. If the induration is of 5 millimeters or more, we say that it is a positive Leishmanian test. And the most important thing to remember is that in case of Kala-Azar, because of the widespread immune reaction, the test is negative. It will be positive in cutaneous and or cured Leishmaniasis, but it is going to be negative in an active visceral Leishmaniasis. Number two, detection of antibodies, various tests. I told you just to remember these test names: complement fixation test, counter immunoelectrophoresis, indirect immunofluorescence test, ELISA, and indirect heme aggregation test. We can also detect the antigens in the blood or the body fluids. That is, we are going to detect the antigen of the present on the surface of the amastigote. And this is known as the this is done by the help of the ELISA or the indirect immunofluorescence test. Certain advanced testing has also been carried out and is in place in developed countries like America. That is, number one is the dot ELISA, number two is isoenzyme analysis, indirect immunofluorescence test using monoclonal antibodies, and the PCR. Then we have post-Kala-Azar dermal leishmaniasis. This is a complication of Kala-Azar, and it develops after the patient has recovered, and it occurs in 2 to 10% of the cases about 2 years after recovery. And mostly it is seen in India in patients who have been treated with antimony. There is some link between the development of the disease and the presence of antimony in the body, or it can also spontaneously develop in those individuals who have not taken any medication and the condition just cleared on its own. Again, the cutaneous lesions are present, but they are not ulcerated. In case of Leishmania, uh, Resiliences and Tropica, you were seeing the cutaneous lesions which were ulcerated. In post-Kala-Azar dermal leishmaniasis, the lesions they are going to be non-ulcerated. So this is the clinical picture. These sort of nodules they develop on the whole of the body in a patient who has recovered from Kala-Azar. And these nodules, they are depigmented, that is, the color is lighter as compared to the color of the skin, and they are present on the trunk and the extremities as well as the face. They can be accompanied by erythematous patches on the face, giving it a butterfly sort of a configuration. These nodules, they never ulcerate. They may become yellowish in color, they may become pink in color, but they will never ulcerate. And the diagnosis is based upon the biopsy taken from these nodules and carrying out a microscopic examination. Any questions till this point?
No, ma'am.
Okay. So, ये मुझे वो दूसरी स्क्रीन ऑन कर So, with this, we are going to complete the protozoology. And from Monday onwards, we are going to start with the second part, which is the helminthology. And helminthology, as I told you all previously, it has two components, the cestodes and the nematodes. And hopefully, in the next week, we will finish those two components as well. So I was very happy with the feedback which you gave me. And I thought that I would go over the notes which I made so that I can at least explain to you what was in my mind when I was making these notes. Basically, parasitology, you get one question, but that one question, if you attempt properly, you can get 4.5 marks out of that one question. Number one. Number two, there are not too many of these parasites, and it is going to take a very short time for you to remember them. If you keep on just giving 15 to 20 minutes every day, you will finish it off in about 10 days time. And by the end, and if you keep on giving it a little bit more time, you will be able to repeat it twice or thrice, and then you will be prepared for your final exam. At that point, you will not be wasting a lot of time on parasitology. Amongst the parasites which you studied till date, Entamoeba histolytica, Plasmodium, these are the two main, most important parasites on which you are going to get questions from this portion of parasitology. But when we talk about STDs, Trichomonas vaginalis is a very, very common question. But it's a very small parasite, giardiasis, it's a very small parasite which does not require more than 10 or 15, 10 or 12 points which you need to remember. Because Entamoeba has lots of questions and lots of importance during your viva as well. So these notes were catering to your, not only to your SCQ, but to your viva. So, and it's not necessary for you to remember each and everything which has been written down. For example, if we are talking about amoebae and we are talking about commensals and non-commensals or the pathogenic forms, we just need to remember one species. Maximum, if you're that, but if you can, another. But any one or two, Entamoeba coli and one another, that is more than sufficient. Pathogenic, you have just one. Free-living amoeba, mostly examiners are asking questions because of the occurrence of Naegleria and Acanthamoeba infections in Pakistan in association with contaminated water supplies or in association with pool water being contaminated. And since both of them infect the eye, they can cause a severe infection and they can cause blindness as well. So these are the 3 things or 4 points which you need to remember from this chart, nothing else. Geographical distribution, habitat, and transmission, very important. This diagram so that you can make the organisms when you are attempting the question. Generally, the organisms which we see in the diagrams which we see in the book, they are difficult to copy. A black and white diagram is easier to copy. So this was just because of that. And the trophozoite, these things you need. I haven't given you the sizes, I haven't given you anything else, but these were the minimum things which an individual is going to ask you. Question is going to come, which is the infective form of the parasite? So it's not the trophozoite, which is the active form, it is the cyst form of the parasite. What's the difference between a trophozoite and a cyst? How are the cysts killed? How can you stop the transmission or spread of amoebiasis in a community? If you know that the cysts are susceptible to heat or freezing, drying, then you are able to answer this question. Life cycle, you need to remember one diagram. And you need to add these points because they were there for you to explain the diagram. And if you were reading these notes, for you not to go into the book to look up what is required. So basically, if you take this diagram and you just supplement it with 1 or 2 points from here, which explains this diagram, then you need not remember anything else. This was just for your clarification or for your concept clearing. Pathogenesis is very important, and questions on Entamoeba histolytica, they are most commonly targeting either the life cycle or the pathogenesis. So the pathogenesis starts with the transmission, a little bit of the life cycle, and then what happens in the intestinal lumen and how it produces that disease. Most important, which none of the papers which I have come across in the past mention the pathology. Pathogenesis is basically about the pathology and how that pathology is being produced. That is why when we are talking about parasites, we need to briefly mention the transmission as well as the life cycle points which take the pathogen or which take the parasite to the place where it is going to produce the pathology. So you need to trace the pathway of the parasite once it goes into the body till it reaches the site where it is going to produce the lesion. And that becomes a part of your pathogenesis. And then what happens at that site, that is also very important. For example, in case of Entamoeba, you are talking about the formation of flower-shaped ulcers. You need to know that they are flower-shaped ulcers, they are going to spread towards the lateral margins because the area below, which is the muscularis mucosa, does not allow it to spread in a vertical direction. And the ulcers are going to be having raised margins and they will have the parasites at the edge of the margin. So these are few pointers which you need to know. Again, this is just a brief diagram to make you remember things. Cysts and trophozoites, they are going to be passed in the fecal matter, but for the transmission, you see that only the cysts are going to go and cause a disease. Then this is the cycle, and the trophozoite forms are going to be present in the blood, and they are going to cause the disease over there. These diagrams at times, when you look at them, what I have found for myself, and I hope it works for you as well, is that the diagram gives you the clues to answers to different questions. You may not remember that the cyst is the infective form after reading a line. But if you have seen a diagram which shows you that the cyst is passing out into pieces and it is going into the mouth, into the human, then maybe when you are asked the question, which is the infective form of Amoeba histolytica, it certainly comes into your mind that it is a cyst. So you do not need to memorize such things if you have concepts regarding the cell life cycle of the pathogen. Clinical manifestations, incubation period, all MCQs, all not MCQs, rather these are questions regarding your viva. And when you are given a question on parasitology, you will always be given a small clinical scenario so that you are able to pick up the parasite which we are talking about. So if you don't know what are the clinical manifestations of intestinal amoebiasis of amoebic dysentery, you will not be able to understand the pathogen which they want you to identify. So if you are not going to identify an Amoeba histolytica, all the questions related to that organism which are going to be a part of that question, you will not get any marks for that. So this clinical course or the clinical symptoms, they tend to give you the clinical picture which is going to point out about Amoeba histolytica. Then we have the lab diagnosis, and lab diagnosis, you can make it as simple as you want. And this is a very important question because these differences between amoebic and bacillary dysentery, they come as a part of your SEQ and they're very commonly asked in your viva. A very favorite question of the examiners. And these are the tests which I have mentioned, and the complications, another viva question. You get a short essay question on amoeboma or an amoebic liver abscess. At the end, it all depends on you people, how much you want to take from this notes, or you want to study your book. This is just for your to make things easier for you. If you are more comfortable reading the book, I would suggest that you do that. If you find something here which is better, utilize that. But at the end of the day, it is it's your study, and you need to study according to what is suitable for you, what works for you rather. I will keep on giving you some notes because I am targeting most of the time. I am targeting the viva questions, the SEQ questions, and I am making these notes for you so that you can answer those questions. So if you study the book and then just briefly go over these notes, that is going to help you even more. Any questions? Any questions from your end?
No, ma'am.
No,
Okay, thank you so much.
मैम
जी,
मैम आपसे बात करनी थी कोई ये जो हमारी टर्म हो रही है
हाँ जी,
मंडे से,
हाँ,
तो इस बारे में हमने भी सर से भी बात की थी लास्ट लेक्चर के अंदर, तो कि जो उन्होंने वो सेफ एग्जाम ब्राउजर कोई पता नहीं इंट्रोड्यूस कराया है,
हाँ जी,
तो वो तो जो बच्चे काफी बच्चों के पास लैपटॉप नहीं है और वो सिर्फ लैपटॉप के ऊपर डाउनलोड होती है।
जी बेटा,
उसके अलावा ये इशू है कि जो बच्चे डाउनलोड भी कर रहे हैं,
हाँ,
डाउनलोड हो जाती, कुछ बच्चों की अगर डाउनलोड हो भी गई है तो वो जो टेस्ट करने लगते हैं, कल मॉक टेस्ट हुआ था एक, उसके
हाँ।
ऊपर उनका कॉन्फ़िगरेशन एरर आ जाता है और वो चलती नहीं है। ठीक है, तो अगर ये सिचुएशन है और वो फिर कह रहे हैं कि हमने लेना ही उस पे, तो फिर ये तो मुश्किल हो जाएगा हमारी टर्म अगर इस तरह ही कंडक्ट करते हैं।
अच्छा, आप ये कह रहे हो कि स्टूडेंट्स के पास लैपटॉप की अवेलेबिलिटी नहीं है, ठीक है? तो
जी
बेटा
जी
आजकल के
बिल्कुल।
जमाने में तो हर एक के पास लैपटॉप है।
मैम जरूरी नहीं है
अपने
जब
पास
से
नहीं
मोबाइल
होता,
फोन्स आए।
अपने पास नहीं होता तो किसी ना किसी फैमिली मेंबर के पास तो जरूर होता है।
मैम जो
मैम
हॉस्टलाइट्स हैं,
जी बेटा, हॉस्टलाइट्स को क्या
मैम
हुआ?
मैम
काफी
उनके
बच्चे
पास
इधर भी हैं।
बेटा एक बोले ना तो मुझे आवाज आएगी। जी
फिजान बोल लो।
नहीं वो कह रहे हैं कि काफी बच्चे हैं जो इधर हॉस्टल्स में ही रह रहे हैं, अभी वापस नहीं गए थे अपने घरों में,
अच्छा
तो उनके पास भी लैपटॉप्स नहीं है।
अच्छा,
फिर काफी बच्चे हैं जिनके पास नहीं है, जो
ठीक है
क्योंकि
चलो।
आजकल मोबाइल फोन्स वगैरह के ऊपर यूज होते हैं। और अच्छा जिनका हो भी गया उनकी भी नहीं चल रही है, आप
अच्छा
उनकी भी कॉन्फ़िगरेशन एरर देता है वो आगे से।
मैम रिक्वेस्ट है कि हमारी टर्म या तो फिजिकल ले लें या तो मैम ऑनलाइन में बहुत ज्यादा दूसरे एरर्स आ जाते हैं, और टर्म जो है इम्पोर्टेंट एक आपका एग्जाम होता है, अगर इसमें खराब हो गया तो हम लोग का काफी इंटरनल पे इफेक्ट पड़ेगा। टेस्ट की तो खैर होती है, लेकिन मैम प्लीज टर्म की रिक्वेस्ट है कि या ये फिजिकल ले लें, आप वीक ठहर जाएं, जब नेक्स्ट वीक खुलेंगे देन आप ले लीजिएगा टर्म, लेकिन वो प्लीज फिजिकल लें।
अच्छा बेटा ठीक है, और एनीथिंग एल्स?
मैम वो जो लैपटॉप का आप कह रही हैं, आजकल जो फोन्स होते हैं ना उसके ऊपर डेस्कटॉप साइट्स भी खुल जाती हैं,
बिल्कुल
तो फोन्स हमारे पास हैं लेकिन लैपटॉप्स की अवेलेबिलिटी थोड़ा इशू है। वो इस वजह से जनरली आपको बता रहे थे कि ये एक्सक्यूज नहीं है, लेकिन जहाँ फोन के ऊपर होता है मैक्सिमम वहाँ पे उसको ट्राई करते हैं अप्रोच करने की, लेकिन
ठीक है
अभी ये लैपटॉप का भी थोड़ा इशू आ रहा है।
चलें ठीक है, आई अंडरस्टैंड
मैम
योर प्रॉब्लम। हाँ
अगर मैम ऑनलाइन की लेनी है तो एलएमएस पे फिर ले लें, क्योंकि हमारा ब्राउजर तो चल ही नहीं रहा, जो भी सेफ ब्राउजर है वो।
एलएमएस पे आप लोग जो है ना एक्चुअली चीजें आप लोग खुद अपने लिए डिफिकल्ट करते हो। एलएमएस में मसला पता है क्या, मेरा अपना एक्सपीरियंस यहाँ से पहले भी यही रहा है, और मैंने पेपर्स, ये मैं किसी की बात नहीं कर रही, ये मैंने खुद पेपर्स चेक किए हुए, मैं उनकी बात कर रही हूँ। एलएमएस के ऊपर जो हमने क्वेश्चंस अटेम्प्ट करवाए, ठीक है, आप टू अ सर्टेन एक्सटेंट आप लोगों को सबको पता है कि एमसीक्यू शफल हो जाते हैं, ये हो जाता है, वो हो जाता है, एंड थिंग्स आर एटलीस्ट मैनेजेबल ऑन इन केस ऑफ एमसीक्यूज। बट जब हम बात करते हैं एससीक्यूज की, आई डोंट नो व्हाट यू पीपल डू। मैंने बच्चों के पेपर्स चेक किए हुए जिनके अंदर कट पेस्ट हुआ हुआ है, अगर एक एरर है ना स्पेलिंग मिस्टेक का, तो वो 50 के 50 जब जितने भी स्टूडेंट्स के मैंने पेपर्स चेक किए उन सब में वो अगर कट पेस्ट हुआ हुआ है तो वो एरर वहीं का वहीं मौजूद है। अगर
मैम
मिड
सिर्फ
ऑफ द,
एमसीक्यू
जी बेटा एससीक्यूज
कंटिन्यू
की
मैम।
बात कर रही हूँ बेटा, एससीक्यूज की बात कर रही हूँ, बिकॉज खाली एमसीक्यू इज नॉट योर क्राइटेरिया फॉर द एग्जाम ना, आपको एससीक्यूज भी तो देने ही देने हैं ना। अब ये सॉर्ट आउट करते हैं बैठ के बेटा, सॉर्ट आउट करते हैं। आई विल टॉक टू डॉक्टर सायरा अबाउट इट, आई विल गो एंड हैव अ मीटिंग विद हर। आप लोगों की मेरे साथ ये डिस्कशन हुई है, लेट्स सी कि
जी
हम इसको किस तरह से एड्रेस करते हैं, एमसीक्यूज का नंबर बढ़ाते हैं, बिकॉज एससीक्यूज ऑन एलएमएस इट्स जस्ट आई डोंट थिंक सो इट हैज गॉट एनी वर्थ और वैल्यू कि आपने वो अटेम्प्ट किया क्वेश्चन। बहुत कम बच्चे ऐसे होंगे जिन्होंने अपनी नॉलेज से वो क्वेश्चंस अटेम्प्ट करते हैं। मोस्ट ऑफ यू आर either reading it from the book and writing, और चलो अगर किताब में से देख के भी पढ़ लेते, but most of the time it's being cut paste and circulated amongst you people। और आपको भी पता है ये बात मैं सही कह रही हूँ। हाँ
मैम फिर इसका बेहतर सोल्यूशन यही है ना कि जब हम कॉलेज आए, एक हफ्ते की बात है, आप तब टर्म ले लें हमसे, तब तक हम अपना
यस
दूसरा
मैम,
सिलेबस ऑनलाइन कवर कर लेते हैं। उसके बाद भी तो हमने ऑनलाइन पढ़ना ही है ना, वो क्लासेस में जाके भी पढ़ना ही है, तो तब हम टर्म दे देंगे, अभी हम अपना सिलेबस कवर कर लेते हैं सिंपल, और ना आपको इशू होगा ना हमें इशू होगा, कोई टेक्निकल एरर भी नहीं आएगा।
चलो बेटा, आई विल गो एंड डिस्कस दिस विद डॉक्टर सायरा एंड विद द रेस्ट ऑफ द थर्ड ईयर टीचर्स, और फिर जिस तरह से जो भी कंसेंसस बनता है वी विल लेट यू नो। आई कैन अंडरस्टैंड।
थैंक यू मैम, लेकिन आई थिंक मैम यही एक बेटर सोल्यूशन होगा, क्योंकि लैपटॉप्स वाला इशू भी खत्म हो जाएगा और सॉफ्टवेयर वाला भी, और बच्चे सुकून से अपनी प्रिपरेशन भी कर लेंगे और फिजिकल हम प्रिपेयर भी हो जाएंगे।
ठीक है बेटा, मैं आई अंडरस्टैंड योर व्यू पॉइंट एंड आई अंडरस्टैंड कि आप लोग अगर एक चीज की बेहतर तरीके से यूटिलिटी को इस्तेमाल करना चाह रहे हो, या यू वांट टू at least अगर आपने term test देना है तो you want to give it at in the best optimal conditions and prepare for it और उसको attempt to optimally करो. तो उस situation में I can understand that. I'm going to talk about it. ठीक है? I'll talk about it and I agree with this suggestion that we can delay it, we can postpone it. But although this can be my opinion, I can side with you, but it has to come as a unanimous decision. जो आपकी थर्ड ईयर की फैकल्टी के हेड्स हैं उन सब का एक यूनानिमस डिसीजन होगा. ऑल्दो के आई लाइक दिस आइडिया कि हम इसको थोड़ा आगे करके आपको फिजिकली ही हम आपका टर्म टेस्ट लें, बट आई कैन नॉट मेक एनी प्रॉमिसेस एंड आई कैन नॉट मेक एनी कमिटमेंट ऑन द पार्ट ऑफ द थर्ड ईयर फैकल्टी, मतलब थर्ड ईयर की जो हमारी आपकी टीम है, ठीक है ना, हेड ऑफ द डिपार्टमेंट की. और डॉक्टर सारा जब तक हम सब मिलके इस चीज को एक यूनानिमसली नहीं डिसाइड करते तब तक आप समझो कि आपने मंडे को टेस्ट देना है. ठीक है?
ओके मैम, थैंक
ठीक
यू.
है. आई विल ट्राई 100% टू कन्विंस द रेस्ट. राइट?
Thank you, ma'am.
ओके.
But in return what I want is your commitment to studies.
Inshallah.
ठीक है. हाँ बेटा, बात मसला पता है मुझे क्या इशू क्या आ रहा है. इशू ये हो रहा है कि there are very few people who are responding. बाकी सब I don't know, मुझे रिस्पॉन्स नहीं मिलता तो आई फील कि आप लोगों को समझ नहीं आ रही या आप लोग इंटरेस्टेड नहीं हो. कितने लोग कहते हैं कि ऑनलाइन नहीं होना चाहिए और फिजिकल होना चाहिए आउट ऑफ योर 100 क्लास?
Almost everyone.
Ma'am, almost everyone.
सबको यही है कि फिजिकल
बहुत
होनी
कम
चाहिए.
बच्चे.
ऑनलाइन बहुत कम लोग कह रहे हैं.
मैम किसी का भी कोई एरर आ सकता है, इंटरनेट कनेक्टिविटी का इशू कुछ भी हो सकता है.
ठीक है बेटा, ठीक है, ठीक है. I'll take this up. ठीक है. So see
थैंक यू मैम.
you on Monday, हाँ, inshallah. Thanks a lot.
Okay, ma'am. Thank you. Allah Hafiz.
Allah Hafiz.